Look at the boomers right now. Look at all the pissed 75-year-olds who say, is it too late? Can I get on it now? I want to get on it now. Right. And so you tell all your 50-year-olds who don't want to be on it, you'll come knocking because you're seeing the hip fractures, you're seeing the dementia, you're seeing the people not do well, and now your really eyes are opened.
Welcome back to Hot Flashes and Cool Topics. Today, we have a guest on that honestly should have been on like a million times by now, but please welcome to the show, Dr. Kelly Casperson. Welcome.
Thanks for having me.
Well, we're thrilled because you are doing such amazing work for women's health. And, we've been doing this podcast 5 years and we've heard a lot of stories, and some of them are the same.
Congratulations.
Oh,
Oh,
thank
thank
you.
you.
Thanks.
I just hit five on mine. Five,
Yeah.
2.3% of all podcasts make it to five.
Wow.
Well, see, we're in a lucky
There you
group.
go. Yeah,
Yes,
We
that's
already have a
celebrating.
connection.
Yeah.
But it's because there's just, you think that you're showing one thing and then there's five other things that open up from that topic. So it's just never ending. And there's some women need information so that they can make educated decisions on their body. And one of the topics that we hear a lot about is sexual health, especially in the postmenopause world where Bridget and I have finally gotten to, thank goodness. And women still have this anxiety over talking about their sexual health. It's like it's still taboo. Why do you think, with all the conversations on menopause, women are still finding it challenging to talk to their doctors about sexual health?
Oh, I mean, there's so many layers, right? Like sex is everything and then never talked about. I was just doing a stage show last week for the M Factor documentary, and I'm like, I have the two biggest niches in the entire world, menopause, like women and sex. And I'm like, and nobody wants to talk about either one of them. So here I am. But I mean, it's like society's shame. Doctors didn't get trained. Doctors don't know what the hell they're doing with female sexuality. And like, I'm allowed to say that because I didn't know what I was doing. And I'm a urologist. So I was like definitely trained in the male. And I was literally told, don't worry, the gynecologists are taking care of them. And when you do the math, like the math doesn't math. So there's about 50,000 gynecologists, OB-GYNs in America practicing right now. And that is projected to go down to about 47,000. So it's going to get worse. And a lot of those are delivering babies and doing hysterectomies and, birth control. It's like, which one of them are supposed to be taking care of 50% of the population's sexual health? Like the math just doesn't add up. The other bias is that people think that OB-GYNs are the only doctors for women, which is absolutely absurd. 50,000 doctors, it's not enough. We've got 80 million women over the age of 40 in America. Primary care needs to take care of this. Internal medicine needs to take care of this. Like OB-GYN can't be the only sex med doctors. There's just not enough of them.
Right. In your book, your first book, I know that the second one's going to come out September 2nd, but I'm going to hold up a cover. If anybody is watching a video of this, You Are Not Broken, and Stop Shooting All Over Your Sex Life, which I love. You address so many things that women our age were taught societally, just, oh, you can't talk about this. And as I read your book, it hit like religion. How were you brought up religiously, and what told you that's bad? Your parents didn't talk to you about it, or if they did, can you address how that was an issue and how that affects women now, like especially we're postmenopausal and we're hitting this thing where my libido is not working anymore. I don't know what to do. I don't know what's happening. Can you talk about what happened to us in the past that is holding us back?
Yeah. So sex is biopsychosocial, right? Biologic, psychologic, social logic of like, I always come back to the biggest problem is we don't get sex ed and we don't get adult sex ed, right? Like as a teenager, you got a disease and pregnancy prevention plan. If you were lucky, the people who say, like it's the very rare person who's like, my mom told me everything I needed to know and to prioritize my pleasure and what the clitoris is. And like, it's the rare person who's has that mom. But like if anybody got good sex ed, it's either from a mom or like a very good early relationship. And most people don't have very good early sexual relationships because they're having sex with somebody else who also didn't get sex ed, right? So you're limping along, like probably with the help of some hormones. And then midlife happens, and you're like, well, my relationship's routine. It's not new anymore. Like the newness factor of relationships goes a long way. And the brain thinks things aren't new after about a year, right? So relationship might not be new. So you don't have that like dopamine surge. You don't have the hormone surge. And then you're like, oh my God, everything I learned about sex was wrong in the first place and not even neutral. It's like negative, right? Like just sit around and wait for Prince Charming to come and then he's supposed to turn you on all the time and he gives you the orgasm. You're not in control of that, right? Like there's all these like unspoken dogma and then you're like, "Oh my God, it's all wrong." You mean I'm the one? This is my sex life. You're like, "Yeah, it's your sex life." And then women are like, I don't know. I don't know anything.
And I would suggest if people haven't who are listening that they go over to YouTube and watch your TED Talk because you do
Thank
talk
you.
a lot about the biopsychosocial aspects. And can we talk a little bit about more about the dopamine in the brain? Because one of the things that you said that struck with me is, are you having sex worth desiring?
Yeah.
And
Well,
that's just women don't even ask themselves that question.
that's a good question though, right? Like
Absolutely.
I was talking to a expert in female sexual health and we were talking about low desire and what's available for low desire. And I looked at him, this is an aha moment like years ago. And I looked at him and I'm like, you're assuming women are having good sex. And he's like, well, yeah. And I'm like, oh, well, that's a pretty big assumption, right? Like, it's one thing if you have low desire and it's good sex, and it's another thing when you have low desire and it's mushy broccoli and like painful nails on a chalkboard, right? Like, you're never ever going to desire the latter one. So that's like, and then to go back to dopamine. So dopamine's actually released in the brain. People think you get like a dopamine hit when you get something. Dopamine's actually released in the anticipation of getting the rewarding thing, but the thing has to be rewarding, right? You're not going to get that dopamine from like making out with cardboard. So,
Yeah. And you talk
so
about responsive. Yeah. Spontaneous.
yeah, so
versus
so the two
responsive.
types of again, Hollywood tells us you're supposed to be spontaneously desiring all the time. Any gender, men feel broken when they don't spontaneously desire sex, and it's very normal for not everybody to desire sex all the time, right? Like we wouldn't have a functioning society if all we did was crave sex 24 hours a day. So everybody thinks spontaneous desire is the default. That's what Hollywood says. That's what your top 10 country hits say, right? And then they get into midlife and they're like, but I'm not just sitting around. Like they feel like there's something wrong with them. And it's like, well, do you like sex? And they're like, oh, yeah, I like sex. And I'm like, you have a good time at the party? And they're like, oh, yeah, I have a good time at the party. And I'm like, well, that's spontaneous. That's responsive desire, meaning you're not sitting, you're doing a job, you're writing a podcast, you're writing a book, you're taking the dog out to poop. Like, you're not thinking about sex when sexual context isn't present. But when you put yourself in a sexual context, you're like, yep, good party, love it, great. That's normal. That's totally an adult brain normal. And so many people, Rosemary Bassan was one of the researchers to kind of like discuss how female desire is different. It's like you can desire sex during sex, you can desire sex after sex. And people are like, what? And it's like, well, how many times are people like, oh my God, that was so amazing. I loved that. Remind me that we should do that all the time. We should probably do that every day. I like that so much. That's somebody desiring sex after they just had sex, right? But if you don't get adult sex ed to be taught this, you think you're broken. It's like, no, you're not broken. You just didn't learn the rules in the first place.
Right. So many women, I mean, goodness, we hear this so much, Colleen, about people. What do we do about this? And a big thing you bring up a lot, not only in your book, but in your podcast of the same name, You Are Not Broken, is you call it PIV, penis and vagina sex. And that is not the only kind of sex. Can you talk about why that is an issue?
Yeah, so it's the heteronormative view of what sex is an erect penis goes in a wet vagina and then somebody orgasms and then usually sex is done. That somebody who orgasms is usually the male because that is a very effective way for a male to have an orgasm. Highly effective. 70% of women don't have an orgasm by putting something in their vagina because the vagina is not to be crass, and this is not a perfect example, but the vagina is kind of like the scrotum in the fact of like it's close, but rub a scrotum and see how many orgasms you get, right? Is like you have to care about the organ of pleasure, which is the clitoris. So, one of the big things we see in heterosexual relationships is what we call the orgasm gap. And that is the persistent, they've been studying this for a while, it continues that men have more orgasms than women. Well, if somebody's getting more pleasure out of this event than the other person, don't be shocked that one person doesn't want to do it as much. And then she goes around beating herself up for having low desire. And it's like, no, your reward isn't as good. So focus on sex worth desiring, and then we can worry about desire. Now, there are things available that help with sexual desire. Usually it's assumed that you're working on sex being a good thing, though. I can't make you desire something that's not worth desiring.
And for some women, they don't desire it because it hurts.
That's
Sex
right.
can
Yeah.
hurt. Can we talk about that?
Yeah. Well, women come in to see me and they're like, I have two problems. I have low desire and I have pain with sex. And I always like taking problems away from people. And I'm like, no, you have one problem. You have pain with sex. Nobody desires that. Right. So you have to work with that. So genital urinary syndrome of menopause, which is a huge mouthful, but women don't understand that women don't understand what menopause is, first of all. If you think this is just a hot flash and your periods end, you're woefully and uneducated about what's actually happening in your body. So ovarian function of hormones, both estrogen and testosterone and progesterone, go down. Other hormones too, but those are the commercially available ones. So that's why we talk about them. But they go down, they cause changes throughout your body. And in the pelvis, it's painful sex, thinning of the vulva, resorption of your labia minora, clitoral atrophy, decreased arousal, it's a lot more hard to have an orgasm, pain with penetration. All of that is because your hormones go down. And so the other thing about it is it can happen like after your periods end. So women, they'll see me 7 years and they'll be like, I haven't had sex in 7 years. Or they'll be like, how is this menopause? And I'm like, because you don't understand it's low hormones, that the situation keeps getting worse. But very treatable. You just have to be on top of it. We think the sex med docs and the hormone docs were like, vaginal estrogen is so safe, so inexpensive. And if 50 to 80% of women get these problems in their pelvis, why wouldn't you want to focus more on a preventative regimen than like, hey, make sure to go see your doctor when you can't have sex anymore because it hurts like razor blades, and then try to undo the pain cycle you created.
Right. And vaginal estrogen, I have it and it is awesome. It's great. And then you also, can you address the fact that it's safe for people that even it's non-systemic. So can you address that?
Yeah.
And how you're really working hard to get this black box label removed from
Yep.
vaginal estrogen?
So when we talk about hormones, we talk about two different things, meaning systemic and local. Local is also called vaginal because you tend to put it in your vagina, also on your vulva. Very, very low dose. A year's worth of vaginal estrogen is equivalent to one tab of oral estradiol. And remember, one tab of oral estradiol is still like 10% of what one birth control pill is. So let's just zoom down to like how minimal of hormones this is. And 75% of women at some point in their life took birth control pills. So don't tell me you're afraid of hormones, right? So the vaginal estrogen has a boxed warning on it, as do all estrogen products, because of the WHI. That was this big study in 2002, basically said, hey, throwing high dose synthetic hormones on people who aren't very healthy can cause some side effects. And actually that was overblown. There's way less side effects than the media took. But because of that, the FDA said estrogen needs a boxed warning, which is the highest level of warning that the FDA can put on something. And so to this day, even on vaginal estrogen, which doesn't go, if I drew your blood, I wouldn't know you were on vaginal estrogen. That's how low it is. But it says heart disease, cancer, blood clot, And then it says probable dementia, not possible dementia, probable dementia. So there's a study that was recently published that said even if a woman was lucky enough to get a prescription for vaginal estrogen, because it's a prescription in America, 23% of them still won't use it because they go home and they read the label.
That's
But
heartbreaking to
yet
me.
now
Yeah,
now
yeah,
women will put just
yeah.
about anything on their face for skincare. And I love that you use that argument. It's skincare, just a different area of skin. I mean, we're quick to put estrogen on on our face. We're quick to put all these chemicals on our face, yet we're still
We're
afraid.
quick to drink alcohol.
Mhm.
Sure.
It's a known carcinogen. I did a real, it was like the tale of two government warning labels. Because the vaginal estrogen one is basically like, it'll kill you. Be real damn sure you want to use this. And then the alcohol one's like, don't use while you're pregnant or operating heavy machinery. And I'm like, that's not applicable to most people.
Yeah.
Do you think that this kind of groundswell movement will make them take a listen to it? Because they haven't as of yet in other ways.
I'm a pretty optimistic person. Like by default, I'm pretty optimistic, but I'm like, physicians have tried twice. The most recent meeting with the FDA was like June 2024. So physicians have met with the FDA, and the one before that was like 4 or 5 years ago. And both times they won't take the label off. And then, so now we have a citizens petition, basically making it very easy. You can go on to letstalkmenopause.org. There's a button for unboxing estrogen. If you're a provider, you click this button. If you're a layperson, you click this button. It's been really sweet because like I have a pretty international audience now on Instagram and they're like, I live in Canada. Can I click the button? And I'm like, well, I don't think the FDA really works for you, but nice. But it's amazing how many women don't value that their voice matters. You know, they're like, what can we do? And like they're so upset about things now, which is great, wonderful. We've got them upset, but it's like do something about it. Another one that I'm hearing a lot these days is insurance is requiring prior authorization for hormones, which is insane because it's your body literally has low hormones. It is the treatment of choice. There's no drug that's more effective than hormones, and that insurance companies are giving another barrier to you receiving care. And I'm like, you better write your legislator. Write your congressperson, write your senator, write your state insurance commissioner. Like, this is absolute bullshit. And it will not get better until women do something with the anger that they have.
Yeah, you're talking about that. I just know personally, I am on a patch, estradiol patch, progestin oral, and then I have my vaginal estrogen. And the past few times that I have gone to get my prescription filled, I was waiting for my refill for my patch, and I got a call that, oh, they haven't refilled it because we haven't gotten results from your mammogram. And it had been 6 months. It wasn't a year. It was 6 months. And I was like, well, I had my mammogram. And I know that my particular physician isn't associated with the hospital where I'll go through to get my mammogram. And I was so shocked. That has never happened to me before. And I said, well, I signed the release that you could have results, but I've never had an issue. I've never had any concerns with a breast cancer scare, or, I don't have it in my family. And I was like, they're not going to give me my patch until I have my mammogram. Have you ever heard of anything like that?
Yeah, I don't mind that actually. Like,
Oh, okay.
you should, if it's only been 6 months, like, yeah, give the woman her hormones because I'll just follow regular mammogram screening guidelines, right? But it's a good time to remind your listeners that hormones are food, right? And so food can feed monsters. Food doesn't cause monsters, but food can feed monsters. So if you have a monster in there, you want to know about it, you got to get rid of your food till you treat the monster. And so that's really important. And it's very, very common that most people who prescribe female menopause hormones, not vaginal estrogen, again, very super low dose, but systemic, will require that their women be up to date on mammograms because you want to detect something if it's there early. And you want to, if there's a monster, get the food out till you treat it.
Right. Yeah. And, I do have a little bit of difficulty with my vaginal estrogen, that it is expensive, even though I have insurance.
Don't use
Uh,
insurance. Don't use
Don't
insurance.
use it. Don't use it. Okay.
Go to send your prescription to Mark Cuban Cost Plus Drugs. That's about $14 plus $5 shipping. You don't have to stand in line. They ship it straight to your house.
Okay.
It is a absolute crime in this country that you pay a ton of money for insurance and then they make money off of you when you fill a prescription. And that in 2025, it's cheaper to get your drugs paying cash than to go through your insurance. My progesterone was like $230 and I paid cash using the GoodRx app, which is another thing to check out for cash-based prices. And it was like $28. So you pay money for insurance and then you enrich them additionally when you give them more money for something that doesn't actually cost that much. Hormones are dirt cheap.
And do you think one of the reasons that the information is not getting out there is because it's not a moneymaker? Testosterone for women, it would not be a moneymaker. I mean, do you think that's one of the issues?
Oh yeah.
Yeah.
100%.
And
why do you think they're coming out with brand name hot flash medications? Because they're synthetic, patentable, expensive, and there's a huge unmet need. It's like most women can safely take hormones. And I don't mean most women like 51%. I mean like most women can safely take hormones. But they're right now in America, but less than 5% are on them. So wrongly, they're going to go get the new brand name, super expensive, $300 a month, like insane medications.
How much is testosterone for men? Do you know how much compared to women? Is it
Well, yeah,
less?
it depends upon how you do it. So if you inject it, that's the cheapest. It's like $10 a week. Um, the gel for men is about, it's for a month's supply for them, it can be like almost $200. So if you dose that for women, that's 1/10 the dose, so like $20 a month. Super cheap. So yeah, testosterone's cheap.
an interesting thing that I was listening to is also when someone asked you about andropause, and you were like, it's more lifestyle than necessarily what they're eating, how they're exercising. Can you talk a little bit about how men's conversations on erectile dysfunction and testosterone use is just kind of blown up and it's fine, but for women, they don't even realize they make testosterone.
Well, and like the huge gender bias on what you should do. So like with a guy doesn't come in with like low T and low libido, and we're like, yeah, well, but that's natural. And I'm really a natural person, so I think you should do it naturally too. And like it's just normal to like have a limp when you're 45, right? Like there's a new yoga class for limp on Tuesdays. Like let's go do that with all the other natural people who want to naturally just age. Like take that conversation, turn it to women, and that's what happens.
Right.
I'm just going to do menopause naturally.
But
I got
it's so yeah.
I got some essential oils. That'll make the ovaries be okay, right?
And I'm
Like
giggling when you say that about the man, but then the woman, it sounds like, yeah, we've all heard this before.
100%. I mean, that's my superpower. My superpower is I'm a urologist, right? Like this whole entire argument, whether it's sex or it's hormones or it's how you want to age, it is gender bias and gender inequality until the cows come home for me. And how women oppress women, how doctors oppress women, how everybody keeps women down from living their best life. We do not do that to men. And until that is equal, I will have a job to do.
Right. And that's also addressed in your book, just circling back to the sex topic, just, sexual relationship, heterosexual relationship, that women just take on all the guilt and if there's an issue going on in your relationship when it comes to sex, women take on that responsibility other than the man. And you really address conversation with your partner. And I know that I was looking for it was your ideal version of sex. And there were 4 steps. And I was reading your book and I gave it to my husband, which I got to say, he's really good about that. So he's like,
Oh, that's awesome. That's so good.
But
Yeah, well, I mean, we didn't get sex ed, right?
Right.
You got disease and pregnancy prevention plan. Where in that did they tell you this is going to be a really hard thing to talk about, but here's some tips for how to do it. And it's okay to fail. And it's okay to try again. And it's okay to not get it right. And it's okay to feel awkward. Right? Like all of that. Because then people are like, okay, I get that I need to talk to my partner about this, but I don't want to fail. I don't want to seem goofy. I don't want it to be awkward. And I'm just like, girlfriend, it's gonna be awkward. Like,
Yeah.
get over it. Right? Like we're adults. We can do adult things. And you know, to me, I'm always like, dude, I'm not making anybody have sex or I'm not making anybody talk about sex. But if you want to improve your life, like what we are doing and limping along is not serving.
We talk a little bit about testosterone in terms of mood, because I think that women don't always understand that the testosterone isn't just for men, it's for you. You make it in your body. It could help your mood a little bit. Can you talk about that?
Yeah. So testosterone is made in the ovaries. Ovaries cannot make estrogen without making testosterone first. So cholesterol, to oversimplify biochem, cholesterol, testosterone, estrogen. So you got to say that first because you can't come out of the gate being like, Kelly thinks people should be on testosterone. And because then people are like, Kelly wants people to transition or be like a man or give them something that's not natural. Right. So you really have to like, be like, nobody told you that your ovaries make testosterone. Nobody told you that your ovaries make 4 times the amount of testosterone than estrogen. Sit on that for a hot sec. Okay, let's move forward. So testosterone starts to decline in women's bodies after your 20s. We don't really know why. We don't know why. Oddly enough, it starts to go up again after you're 70. We don't know why in some women. But those women actually have more heart protection. They have less heart attacks, right? So there's a role for testosterone in heart protection. So much of what I say, though, is extrapolated from observational studies, animal studies, like all this stuff, because again, it's not a branded product. There's not a lot of money in it. It's incredibly expensive to do these studies. So it's very hard for me to say, like, we've got strong data, but with how much we know in men, how much we know in women, like, it's not a leap to say this is a neurohormone. It decreases the risk of joint replacements, in all genders. It decreases the risk of dementia in men. I think this is neuroprotective in women. We don't have great data for me to fall back on. But I'm like, men with low T have a higher rate of dementia. You give a woman testosterone, you ask her how she feels. It's her brain. It is her brain. She's like, I feel more like myself. I have more energy. I don't hit the wall at 3 p.m. I'm not reaching for that cup of coffee. And the other big argument, which I love to point out to people about testosterone and mood, is where's libido?
In your brain.
In your brain.
Yeah.
What is libido? It's a mood.
Yeah, it's mood.
Yeah.
We have multiple randomized controlled, placebo-controlled trials showing testosterone's better than placebo for libido in women. So that's a mood, and it helps your moods. So I mean, the other thing, again with sex is like you don't have a great sex life or libido in a bubble, right? Like everything else can't be shit, but like this one amazing like sex drive and sex life you have. It's usually like it's all part of how you're living your life. And it's like testosterone doesn't just help libido. Like your energy is better. You're more clear. Like you have more like pep in your step, right? Like of course the sex life is going to get better. The other thing about testosterone and libido is testosterone in those studies is actually shown to help all domains of sexuality. So arousal, orgasm, blood flow to the clitoris has been measured. That goes up with testosterone. So it's not that testosterone's just the mood of libido. It's literally like genitals and blood flow and like all those other things. And you're like, if we've measured clitoral artery flow on testosterone, which we have, are you telling me testosterone only works on the clitoral artery for blood flow? Or is it possible it works all over your body for blood flow? Right? Like they're actually they're researching Viagra in men for dementia prevention. And the reason being blood flow. So it's like, doesn't just help blood flow in the penis, It might
Makes
help blood flow
sense.
in other places. So when people get very, like people want, especially on the internet, right? People want black and white. People want yes or no. People want, does it help for this or not? And like, it truly takes the expert to be like, I know all the data and all the pieces and like putting it all together, dismissing testosterone in women is a fool's errand and you're going to be wrong. And it's like, I'm going to be on the right, I'm on the right side of history on this one.
Right.
Besides the fact we've been giving testosterone to women for 80 years. Like this is not new, people.
Can we just clarify for a second the topic or controversial topic of pellets? Because never do we get yelled at more by listeners and followers than we tell them you have to be careful when you're taking pellets. Can you talk about that?
Yeah, so you usually want them to yell at me too now.
Yeah, exactly. Why should we be by
Share the
ourselves?
wealth. Yeah.
Perfect. I actually did an Oprah Daily op-ed on this. So if people want to read it, they can go to Oprah Daily in the search bar, type in testosterone, and it pops up. So why do testosterone? So what are testosterone pellets? Testosterone pellets are medication in a small little, I call it birdseed, a small little pellet, and you make a teeny little incision in your thigh, hip, upper buttock. And it lasts, it's slow release. You can't pull it out once you put it in, but slow release for like usually 4 months, right? So like 3 times a year, you got to go get a pellet. So why do they exist? Pellets exist because women are suffering. They're looking for solutions. Traditional Western-based, insurance-based healthcare is not helping them. And the pellet people can make money off of it, right? Like I don't make any money off of giving you transdermal testosterone. I want you, you're going to come and pay me because of my brain. I'm not making money off of hormones, right? That's like where my ethics lie. So you can make money off of pellets. Pellets are the most expensive, highest dose, most unregulated. And so to me, I'm like, listen, they're an option. Some people are like, they should be banned. I'm like, I don't think they're ever going to be banned. Like, no. But people need to know. And I think it's ethical and fair that if you go in and somebody's like, I think a pellet's best for you, to be like, what else is available and why? And a lot of pellet people don't have it because if you make money off the pellets and you don't make money off of giving somebody a prescription, that's your issue, right? So my view, I think some women benefit from a significantly higher than physiologic dose of testosterone? Yes, I do. Do I know who that woman is? Not off the bat, no. So do I think you should earn your pellet? Yeah. What do I mean by that? Start physiologic testosterone replacement. See how you do. Go up slowly. If you get to the point where you're like, I'm one of those people that like really likes the higher testosterone and I have no side effects that I'm bothered by, and I want to pay more money and I don't want to apply things, weekly or daily, go get a pellet. But that's a minority. That's a minority of people.
Also you're working hard to get the FDA approval of testosterone.
Yeah.
Is that correct? Yeah.
Yeah. Yeah.
Can you talk about that and what we can do to help in that situation?
Yeah. So what you can do for that situation is write the FDA and or write your senators and say, I want to deregulate testosterone because that's its own issue. And I want a female dosed FDA product. If you go to the testosteroneproject.com, that has all of the pillars. The 3 pillars of the testosteroneproject.com is deregulation of testosterone, because right now it's regulated like narcotics and ketamine, which is insane. But there's lots of prohibitive restrictions put on it because of that category. Got put there not because it's unsafe, but because of the Olympic doping scandals of the 80s. Fascinating story, but it needs to be rescued. It's a hormone, just like estrogen, thyroid, insulin. It should be a prescription just like everything else. Number 2, a female dose testosterone product. And then number 3 is for men. Will we get here in my lifetime with women? I don't know. But for men, at least, screening of testosterone. So when you turn 40 or you turn 50 and it's part of your health screening is you get a testosterone level.
And you think
which then one would say, shouldn't women?
Yes.
And you could say, yes. And then you can go down the whole rabbit hole of, is menopause a disease? And that's a whole can of worms. But so remember, in the traditional medical system, you need a disease to get something paid for. So or just looking right. And so it's very interesting when it starts getting into like who's paying for things and screening. If it's not a disease, it's you have to like literally change the paradigm. So I got off track, but
No, but
Okay,
that's
but it's interesting too about,
yeah,
preventative, what you want to be preventative. That's the
proactive versus
whole
reactive.
I think most Gen Xers do. I do not think, certainly insurance companies do not. Western medicine currently, even if Western medicine does, they don't have the bandwidth for that. They can't handle the sick people, let alone all the healthy people who want to stay healthy.
And
So it really, it's a paradigm shift.
it's interesting because you do talk about the fact that as Gen Xers, which we are, we're watching our parents age in not the healthiest way. And we're starting to question, wait a second, what could we put in place so that we age better?
Yeah.
And
I mean, it's insane that screening for the average person for osteoporosis starts at 65. That's insane. Your greatest, rate of bone loss is the last 2 years before your period ends.
Yeah.
So that's 15 years past. Like you're up the creek already.
right. And
Yeah.
it just seems like it's very relatable when you say that because so many of us do have parents that are not aging well and we don't want to walk in their footsteps, so to speak. Do you think it is advisable for women in their 40s to go to their primary and say, listen, I'm concerned about X, Y, and Z. What steps can I take? What tests can I have done to be preventative?
Yeah. I Every woman is allowed to go to their doctor and say anything they want. And
True.
what I mean by that is it's going to be dependent upon if your doctor thinks the same way you do. I mean, the amount of women I see who come to me and they say, "My doctor said come back when you're more sick. You're not sick enough yet."
Really?
But I mean, so this is a good thing to know. Insurance will cover, should cover, a DEXA scan for bone health if you have a first degree relative with osteoporosis. So if your mom has osteoporosis, get in there and get your scan. And truthfully, paying cash for a DEXA it's dirt cheap. It's like $100. So just to know, I just get DEXAs on all my women because I'm like, I just want to know your baseline.
Right.
Like, let's just know where you are because if it, the argument for menopause therapy is symptomatic, treat symptomatic, treat them when they're symptomatic. And to me, I'm like, osteoporosis isn't symptomatic. And we have an FDA approved medication for the prevention of osteoporosis. It's called estrogen. Right. And so
Right.
it's like you're talking out of two sides of your mouth when you're like, only treat the symptomatic women, but we have an FDA approved drug to prevent osteoporosis, but you can't feel osteoporosis. It's like you really do have to be proactive. And for many women, especially many healthy women, the thing you're looking at is you're looking at a hip fracture at 80, right? You're not going to die of cancer. You're not going to die of heart disease. So you can prevent hip fractures by about 50%, 30 to 50% on hormones. We still have gravity. Like we still age, right? We can't prevent all hip fractures, but hormones are huge for bone health. Huge for bone health. I
My
mean, the
last
other thing, because I'm on a prevention bandwagon at this point, we've got two pretty powerful studies suggesting that hormones started early in menopause. What do we mean by early? 50, less than 60, right? Decreases the risk of dementia by about 30%. And for a devastating, deadly, incurable, hardly treatable drug, 30% is actually freaking huge.
Yeah.
Nobody we're shouting it, but like many people, they're like, because people don't know this. The day you get diagnosed with dementia, that started 20 years ago. Like prevention is people are like, they're looking for a cure. And it's like, that's not how this disease works. You got to prevent this thing.
Right. And so many women that we talk to are just different platforms we're on. You brought this up earlier. They're like, oh, I don't want to use hormones. I don't want to use this. And they're going back to the WHI study. They're going
Yeah.
back there to what they've heard. And I mean, Colleen, you're doing a whole lot to get the word out. Colleen and I are doing what we can to get the word out. What can we do to get these women to know that this is a very safe option for them? Is there any other
Yeah.
suggestion?
Well, so you can provide the education, you can provide the knowledge, you can have your amazing 5 year long podcast, which is exceptional, right? And at the end of the day, you got to let adults be adults. It's not your job. This is not your job to make all women understand science and understand the show that happened with the WHI, right? And understand, do you want to think about when you're 73 and what kind of life you want to be living? Right? It's not your job.
Yeah.
And at the end of the day, you say, you know what? I'm going to make the best decision for me. But this is, I mean, two things on this. Number one, the health disparity between the women who are 50 and start hormones and the women who don't start hormones, and then look at them in 10 years. We've got that data. We have data on 65-year-olds who've been on hormones compared to the 65-year-olds who aren't on hormones. Like, that's Medicare data. It's been published, right? Like, what do you want me to say? So number one is health disparities. You're simply going to have less healthcare costs because you've prevented a whole bunch of things. So that's number one. And then number two is look at the boomers right now. Look at all the pissed 75-year-olds who say, is it too late? Can I get on it now? I want to get on it now. Right. And so you tell all your 50-year-olds who don't want to be on it, you'll come knocking because you're seeing the hip fractures, you're seeing the dementia, you're seeing the people not do well. And your really eyes are opened. Right.
Right.
And so
And some
those are my
stop.
two perspectives for people of like, yeah, we know how this plays out.
Mhm. Yeah. And the ones that stopped, I mean, the ones that got that WHI study when it came
In
out
the
and
early
they stopped their
2000s,
hormones
yeah.
when they were in their 50s and they stopped. And you're watching that now and you're watching the osteoporosis. Mother-in-law, I'm thinking of you, but
Yeah.
Well,
really,
yeah.
I'm seeing
I
that.
mean,
Yeah.
and the flip of that coin is not everybody stopped,
Oh, yeah.
right? Some women kept going. They found doctors that kept their prescriptions going. Many doctors knew that the WHI was not applicable to their patients. Those smart doctors kept saying, you know what? I know like it is a storm around them.
Mm.
And they kept the prescriptions going. And now those women are 80, right? And what do those women say? Those women say, over my dead body, you'll burn me with this or you'll put me 6 feet under with this.
That's what
They're
Bridget
not
says.
stopping.
I say that all the time.
Yeah. So,
Oh,
you just ask them, ask the ones who didn't stop.
right.
And why did they not stop? Number one, they had a doctor who truly cared and was able to understand the science and the data to be like, this isn't actually as bad as what the media said. So they were fortunate in that sense. And number two is they knew how much better they did on this stuff. They knew it and they continue to know it. They're still alive, right? I always joke, I'm like, think of a time when 40% of women were on hormones. It was called the 1990s, right? Like we've already lived that.
Right.
Right.
Right. And so it's not a crazy thing to be somebody. I was walking with a friend yesterday and she's like, what would make you happy? 100% of women on hormones? And I'm like, no, I don't need that. I don't think, and I don't think 100% will go on it. Like some truly can't, some don't want to. Like, I don't think that. I'm like, I'd be happy with 50%. Like the 90s had 40%. So I'm not like, let's just go back to how it was and then like get a couple more people on board.
Yeah. I mean, when they're at 5%, is that what you said? 5%?
Yeah.
Yeah, we don't have great data on compounding, and we know a lot of people get compounded hormones. So that part's hard to measure. So it might be 10%. The UK doesn't have compounding, and it all goes through the NHS, so they have really good data, and the UK is about 15% right now.
Thank you so much for coming on this show. This was such a great conversation, and we can't wait to share it with the listeners.
Thank you. It flew by.
It did.
And
It
before
did.
before we end, we want to make sure that everyone knows that you have a new book coming out September 2nd. Right now it's September 2nd. That
Yeah,
date
right now
could
it's September
change.
2nd.
It's called, go ahead. Can you talk about it?
Yeah, so it's called the Menopause Moment. It's like science, hormones, and mindset for optimal longevity or something. Yeah, mindset, hormones, and science for optimal longevity. There you go. The It was interesting. So I wrote You Are Not Broken, Stop Shooting All Over Your Sex Life, and people loved it. And the publisher was like, will you write another sex book? And I'm like, I think I would want to write a menopause book. And this was still like 2 years ago when like there weren't that many menopause books. But to me, I'm like, there's not going to be too many menopause books. There's 80 million women over the age of 40. Everybody's going to listen to a different voice. But what I wanted to create is I wanted to create a very pro hormone book, because so many books are like, talk to your doctor if it's right for you. Like, there's risks and there's benefits, blah, blah, blah. And I'm like, listen, I just need a book that's like, tells you all the benefits. You make up your mind. There's enough fear out there. But I wanted a very supportive pro hormone book. And so that's what I wrote.
Well, hopefully you'll come back on in September and we can talk about the
Yeah,
new
talk
book. We
about it
would love
Happy
to have
to.
you back on. Thank you
Happy
so
to.
much.
Thank
Absolutely.
you.